How do pathologists differentiate psoriasis from other skin conditions? Imagine trying to tell apart similar-looking skin issues. It can be tricky because many skin conditions share features like redness and scaling. That's where pathologists come in. They use a skin biopsy, which is a small sample of skin tissue, to look at the microscopic details. Under the microscope, psoriasis shows some very specific features. The outer skin layer, called the epidermis, becomes thickened, a condition known as hyperkeratosis. The cells in the outermost layer, called keratinocytes, often retain their nuclei in the outer layer, which is called perikeratosis. This is a hallmark of psoriasis and helps distinguish it from other conditions. The granular cell layer, which normally appears as a thin, clear layer, is often lost. The epidermis also shows acanthosis, meaning it thickens vertically. Blood vessels in the skin become dilated and twisted, and there is usually an infiltration of white blood cells, especially lymphocytes, into the skin tissue. These features form a pattern that pathologists recognize as characteristic of psoriasis. Clinicians first look at the skin's appearance and where the lesions are located. Psoriasis usually appears as well-defined, red, scaly patches that often show up symmetrically on the elbows, knees, scalp, and sometimes on the nails or joints. These plaques tend to have a silvery scale and are often itchy but not always. Other skin conditions like eczema, seborrheic dermatitis, fungal infections like tinea or lichen planus can look similar but differ in subtle ways. For example, eczema tends to be more itchy and less sharply defined, while fungal infections may have a different pattern of scale and can be confirmed with fungal tests. If the clinical picture isn't clear, a biopsy is performed. The pathologist examines the tissue under a microscope to look for those distinctive features of psoriasis. Special stains can help rule out fungal infections if needed. For scalp lesions, doctors might differentiate psoriasis from seborrheic dermatitis or tinea capitis by looking at the lesion borders and scales, and sometimes fungal tests or biopsies are used. Drug reactions can also mimic psoriasis but often show different cellular patterns, such as eosinophil infiltration, which are not typical in psoriasis. In essence, pathologists relying on their microscopic view of the skin tissue to identify psoriasis. They look for thickened epidermis, perikeratosis, loss of granular layer, dilated blood vessels, and immune cell infiltration. Combining these findings with clinical information and additional tests ensures an accurate diagnosis. This careful approach helps guide the right treatment plan, making sure patients get the most appropriate care for their skin condition. Always remember, a healthcare professional's evaluation is essential for an accurate diagnosis and personalized treatment.